Okay, good morning, everyone. It's a pleasure to have Dr. Van Spall today with us. I've known her for some years and we're good friends. She actually was one of my office neighbors back at PHRI. So Dr. Van Spall completed her MD and all her postgraduate training at the University of Toronto. And then she went to Harvard University and got herself a Master of Public Health. She's an associate professor of medicine and a cardiologist who's focused basically on heart failure, echocardiography, but women's health at McMaster University. She is a Canadian Institute of Health Research funded scientist, and she's led several heart failure trials at the Population Health Research Institute. She's an adjunct scientist there, and she's actually raised over $4 million in research funding and has won several research awards. She's published in all of the high impact journals like JAMA, Lancet, Circulation, JACC, European Heart Journal, and the list goes on. She's an invited speaker and also very active in media, Twitter, and all these other things. And she's actually very well known within all the meetings as she's a commentator for AHA, ACC, and all these meetings. She also serves as a college in the CHR College of Reviewers and is in the editorial board of several journals. We were just chatting about a very nice paper that she published in the Implicit Heart Journal about peer review and how do we improve these things in publications in medicine. So it's a great pleasure to have Harriette today with us. And thanks, Harriette, for agreeing to present at Rounds today.
I'm so honored to be here. Thank you for your welcome and your very gracious bio there. I'm happy today to talk about some of the newer therapies in heart failure with reduced ejection fraction, focusing on those with class 1 recommendations. And then to spend a bulk of the talk focusing on my research, which is on improving hospital to home care transitions in heart failure, and also in presenting some practical tools to predict risk among your patients who are hospitalized for heart failure. So hospitalization for heart failure, as we all know, is a high risk deal. Patients who are hospitalized face a 4% risk of death while they're under your care and a 25% risk of readmission following discharge. And these numbers vary according to the acuity that the patient presents with and also the level of care provided in your center, and varies across jurisdictions, partly related to the quality of care that patients receive. There are 2 high-risk periods of readmission following hospitalization for heart failure when you look at the trajectory of a patient's life. One is the transition phase following hospitalization, and one is the end-of-life care phase where patients are recurrently hospitalized, but there is less modifiable risk of readmission and death. And paying attention to these 2 phases can improve both clinical outcomes, particularly in the first peak that you see there, and then quality of care and alignment with goals of care when you look at the second peak. The approach to managing heart failure in the hospital includes addressing the underlying causes, initiating and optimizing guideline-directed medical therapy, ensuring response to treatment prior to discharge, and ensuring continuity of care and quality of care following discharge. These are some of the underlying causes that you're all well aware of: ischemia, uncontrolled hypertension, dysrhythmias. Non-adherence to medication regimen is a big thing that we don't frequently ask about. Cardiotoxic, both prescribed and non-prescribed meds. Alcohol use, illicit drug use, and then high output states that can precipitate heart failure, including infections. Most of the trials that have tested the efficacy of interventions have done so among ambulatory patients with heart failure. This is the first GALACTIC trial, not to be confused with the more recent one, that tested the efficacy of aggressive vasodilation using some of our evidence-informed meds versus standard low doses of vasodilators that include ACE inhibitors, ARBs, or sacubitril/valsartan. And of course, we've all been trained to start patients on IV hydralazine and, reduce preload and afterload aggressively. This trial showed that there was no added benefit in that early, intensive, sustained vasodilation approach. That approach did not reduce the endpoint of all-cause death or acute heart failure readmission following hospitalization for heart failure. So the good approach is start your therapies at low doses and discharge patients on the right therapies without the compulsion to aggressively up-titrate those therapies in the inpatient setting. We now have 4 good pillars for heart failure with reduced ejection fraction. Beta blockers, ACE inhibitors, and ARBs are well established. We now know that neprilysin inhibition is preferred over ACE inhibition and ARB therapy from a few trials. MRAs are probably the most underemphasized but efficacious medications that should be added on as therapy, and SGLT2 inhibitors, which have recently surfaced as a therapy to improve outcomes in a range of conditions, including heart failure. The blue highlight is supposed to draw your attention to those drugs that have been tested in patients with NYHA class 4 symptoms. The others, of course, have tested them in NYHA 2 and 3 class symptoms. MRAs, we all know, are efficacious in the post-MI setting and in the chronic heart failure setting. Rails tested the efficacy of spironolactone in patients with NYHA class 4 symptoms, and HFrEF showed a significant reduction in risk of 30% after 36 months of follow-up. Paradigm, we all know, tested the efficacy of sacubitril valsartan in ambulatory patients with heart failure, achieving a risk reduction of 20% in the primary composite outcome of CV death or heart failure hospitalization, and in each of the component outcomes. And on a background of this trial, Pioneer Heart Failure tested the efficacy of sacubitril valsartan at a dose of 200 milligrams twice a day. In patients who were hospitalized with heart failure, the comparator group was enalapril 10 milligrams twice a day. And in this primary endpoint, which was a surrogate endpoint of change in NT-proBNP, demonstrated that sacubitril valsartan reduced NT-proBNP more so than enalapril did. So what is the surrogate outcome? We take this as a sign that it is safe and effective to introduce sacubitril valsartan among inpatients, given that we had the benefit of the larger paradigm trial that showed a reduction in important clinical outcomes. How do you initiate this therapy? Well, among patients with systolic blood pressure between 100 and 120 millimeters of mercury, you could start sacubitril valsartan at 50 milligrams twice a day and up-titrate it once a week in the inpatient setting, keeping in mind that our average length of stay is around 7 to 10 days. In patients with systolic blood pressure over 120 millimeters mercury, you could start the drug at 100 milligrams twice a day. Do not initiate this therapy in those who were hypotensive, who had recent use or need for IV diuretics or vasodilators in the preceding 6 hours, or who used inotropes in the last 24 hours. I'm going to throw on this slide only to give a shout out to SGLT2 inhibitors that weren't tested in the inpatient setting, at least among patients who were non-diabetic with HFrEF. These drugs reduce clinical endpoints in patients with chronic kidney disease, with cardiovascular disease, cardiovascular risk factors, and now we know also in patients with heart failure and reduced ejection fraction, regardless of whether they have diabetes. These two drugs, empagliflozin and dapagliflozin, reduce the composite endpoint of cardiovascular death or heart failure hospitalization in patients with HFrEF almost to the same degree. However, in the DAPA-HF trial, reductions were also seen in cardiovascular death, whereas in EMPEROR Reduce, the main driver was reduction in heart failure hospitalization, likely because EMPEROR Reduced did not achieve the requisite number of deaths in their control group. So it was a statistical issue, despite the risk enrichment strategy that they aimed for to increase the number of deaths in the comparator group, which makes it easier to show drug effect. They did not achieve that number of deaths, and probably driven by that, were not able to show a risk reduction in cardiovascular deaths. Things to keep in mind when initiating SGLT2 inhibitors: canagliflozin should be used cautiously in patients who are on digoxin because the interaction increases your risk of dig toxicity. Genital and urinary infections can be relatively common, so you need to enforce or reinforce the importance of hygiene in the genital area in patients, particularly in women and in uncircumcised men. Hypoglycemia can be increased in the setting of sulfonylureas and insulin. And diabetic ketoacidosis, which did not appear to be a huge risk in any of the trials, is a risk in clinical settings, likely because our clinical populations are broader than those recruited for trials. It's important to hold doses prior to surgeries, prior to states in which we make patients NPO, and to also let patients know if they develop vomiting, diarrhea, fever, that they can hold their drugs to prevent diabetic ketoacidosis. They should know what the signs of diabetic ketoacidosis are. And then renal injury, it's normal to expect a modest decrease in eGFR with initiation. And over the long term, important to keep in mind that patients have a delayed progression to end-stage renal failure in the setting of SGLT2 inhibitor therapy. Volume depletion can be avoided with the strategies we discussed. Watch out for orthostatic hypotension, scale back the diuretics if needed. And lower limb amputations is a risk, particularly in patients with peripheral arterial disease and patients on canagliflozin. I do not use canagliflozin personally. I tend to use dapagliflozin the most commonly. This slide just tells you that with each class of medications, your patients can benefit from additional risk reduction such that the cumulative effect of ACE or ARB, beta blockers, MRAs, and then ARNIs instead of ACE or ARB with SGLT2 can reduce risk in your patients by about 25 to 30% based on where they are in the disease state. Historically, drug classes have been tested on the background of previous drug classes. Biologically, there's no need for us to do this. Biologically, there's no argument for initiating beta blockers and ACE inhibitors, titrating them up to target dose, then adding MRAs, titrating that up to target dose, then if symptomatic, adding on the newer drug therapies. In fact, one would argue that there's lots of evidence that supports a lateral approach to initiating therapies, maintaining your patients in all the right classes, and then incrementally increasing therapies. If our patients had cancer, we would not consider adding one chemotherapeutic agent and seeing how the patient does. We offer them all of the appropriate regimens. We should do the same with heart failure, which has a worse prognosis than many cancers. Things to keep in mind when you are sequencing your drugs. If the patients have an issue with congestion, they're persistently volume overloaded, consider adding SGLT2 inhibitors early on. Consider SGLT2 inhibitors early on also if they have cardiovascular risk factors or known coronary artery disease or chronic kidney disease, because we know that their endpoints improve in those comorbid conditions. If patients have hypotension, then you may not want to add sacubitril valsartan first. You might want to add an SGLT2 inhibitor first or an MRA first. If they have high potassium levels, you might not want to add neprilysin inhibition, but you might add SGLT2 inhibitors because they reduce potassium levels. And if they have issues with the volume status, if they're prone to hypovolemia, you may not want to add SGLT2 inhibitors first. So you can use a common sense approach to sequence the drugs, but make sure that your patients benefit from all four classes. And consider adding an ARNI instead of initiating ACE inhibitors or ARBs first, unless there's an issue with socioeconomic access to these drugs. This is a paper of ours under review where we sort of presented a rationale for the use of certain medications over others. Traditionally, some of the newer trials, I shouldn't say traditionally, but some of the newer trials that were less effective purported that their drugs were not efficacious because their patients were higher risk. And in this paper, we made an argument statistically that in fact, higher risk makes it easier for one to show drug treatment effect because you have higher event rates in your control group by virtue of risk enrichment strategies. And so it's relatively easier to show an absolute risk reduction compared to the control group if you have an effective drug. Here we see on the x-axis the event rates for the composite endpoint of cardiovascular death, heart failure, hospitalization. And forgive me that the 0 is to the right end of the axis and the numbers sort of are decremental in this x-axis figure. We've reversed it for the actual paper. And then on the y-axis, you'll see absolute risk reduction for any given unit of follow-up time. You then see a regression line across the figure. The drugs above the regression line give us the most bang for our buck. So first we see that as risk increases, so as you go from 0 to 50 on the x-axis, your absolute risk reduction increases. So really it's easier to show treatment effect when your risk is higher in the trial population. Secondly, some of the most effective drugs are those above the regression line. So you see MRAs, beta blockers, RNAs, SGLT2 inhibitors above the regression line. And some of the newer drugs, and I don't want to anger the Alberta gods, but we won't say omecamtiv mecarbil. But if you look at Galactic HF or Victoria, which I was referencing there in my Alberta comment, you'll see that they're really less effective. They had minimal reduction in risk, so 8 to 10% reduction in the composite endpoint, despite having high event rates in the control group. And they did not blunt the effect of cardiovascular or all-cause death, which we show in this graph. This is for the outcome of all-cause death, and you see that all of the class 1 drugs really are above the regression line, and some of the newer drugs that were apparently not effective because of high risk are really well below the regression line. I'm going to move now because we talk about drug effect, and I want to bring your attention to the fact that the drug effect has been mainly shown in men. This is our recent work in European Journal of Heart Failure that showed that across the last 20 years, women have been under-enrolled in clinical trials in heart failure with reduced ejection fraction. In fact, a heart failure with any ejection fraction, forming only 25% of 183,000 participants. And in 40% of all trials, there were less than 20% of females recruited. We defined under-enrollment as 20% lower enrollment than the sex distribution of the disease. So we bore in mind that 40% of patients with HFrEF are women, but relative to that, there was a significant under-enrollment. These trends have not changed over the last 20 years. An important predictor of under-enrollment was the use of sex-specific eligibility criteria, so a tip to any clinical trialists in the group to avoid criteria that have to do with menopause, premenopause, having a uterus, being in childbearing years, not being in childbearing years, having lactation, potentially becoming pregnant. Avoid those criteria because regardless, they're associated with under-enrollment. The second interesting criteria that we found were a factor was having male first and last authors. So it gives pause to consider that developing capacity for research and for clinical trial leadership among women, particularly in drug-led trials, which was another predictor of under-enrollment. And we know that drug-led trials choose their investigators rather than vice versa. It has nothing to do with peer-reviewed funding or your proficiency in clinical trial design. It has more to do with being selected. And I'm throwing this out there because it's an important issue that most of us do not think about, and it's the Go Red month for cardiovascular health in women. This is an important issue that we must all consider. So mentor and sponsor your female trainees, guys. This was another paper of ours recently published where we showed that in all of the pivotal trials of heart failure with reduced ejection fraction, women were under-enrolled, and virtually all of the trials did not have adequate power to test for sex interaction. So no idea whether the treatments have different effects in males and females, which we see in real-world settings and registry data, that women have different side effects, they have different tolerability to drugs, because they have different pharmacokinetics and pharmacodynamics, different volume of distribution. It's an important thing that merits recruitment of women in clinical trials for, but is still an issue. The only trial that really had high enough numbers to detect sex differences and that tested for sex differences was the DIDGE trial, and it showed that the toxicity and mortality was higher in females on digoxin than males. I'm transitioning now to transitional care, so hospital to home interventions that improve outcomes. This was our work in European Journal of Heart Failure. We looked at 54 randomized control trials of health services, compared them directly and indirectly through a meta-analysis, and showed that nurse-led home visits were the most effective intervention among health services to improve all-cause readmissions following heart failure hospitalization. This was followed by nurse-led case management, so a case manager in the hospital following the patient home with telephone calls, and heart function clinics. So those were three clear, efficacious health services. These services were also effective at reducing all-cause mortality among clinical trials of health services in patients with heart failure. We combined these services and tested them in the context of a cluster randomized trial using publicly funded healthcare resources in our province of Ontario. We recruited 10 hospitals in a stepped wedge cluster RCT, which is a fun design. Instead of a parallel cluster RCT where half of the cluster is randomized to intervention and half to usual care, in a stepped wedge design, all of the clusters start off with usual care and then are randomly crossed over to receive the intervention in a random sequence. And we compare the effect of the intervention on outcomes in the chunk or wedge that's receiving the intervention versus the wedge that has not received the intervention. Our intervention entailed the three health services that I described. Baseline characteristics were matched in this trial population of around 2,500 patients, but our patients were older with more comorbidities than in mechanistic trials which cherry-pick patients. We did not have any particular eligibility criteria other than patients had to be hospitalized for heart failure. Because of the pragmatic study design and the fact that this was a trial in which we did not micromanage what each site was doing, we coordinated the care, made sure there was integration between publicly funded home care agencies, hospital settings, heart function clinics that in our system are traditionally designed to function in silos. We did all of the work to integrate care and improve bridges of communication, and then had the protocol implemented by these publicly funded personnel, and found that the primary outcomes of time to first readmission, emergent visit or death did not improve with the intervention. And the composite outcome of readmission or emergent visit did not improve at 30 days overall. Importantly, there was a marked reduction in the use of emergent services within 30 days, but not in the composite outcomes themselves. Importantly, the patient-reported outcomes significantly improved. So discharge preparedness, self-efficacy, quality of care transition, and health-related quality of life improved. We then did a sex disaggregated analysis looking at endpoints at 6 months and found a significant sex interaction. I should say that the enrollment of females and males in this trial was 50-50, which was a source of a bit of pride. But we had enough power to look at sex-specific outcomes at 6 months and found sex-specific differences. So while males did not benefit from the intervention in the composite endpoint of readmission, emergent visit, or death. Females did, and they also benefited in the endpoint of all-cause readmission or emergency department visit. Importantly, we did not look at heart failure specific readmissions. We looked at all-cause readmissions because the patient partners in this trial design felt that to them it didn't matter why they were getting readmitted. But this means that the intervention, which would have been more sensitive for heart failure outcomes, was subject to testing for all-cause endpoints. In summary, we found that the transition care services did not improve composite endpoints among all patients, but improved the endpoints among women, possibly because women are older at the time of diagnosis of heart failure, typically do not have a spouse or informal caregiver that they're living with, typically are under-referred for healthcare services. And so relative to usual care in women, the intervention did bring about a significant improvement. We then look at risk prediction. So in heart failure, we have many tools that are complicated, that have 20 plus comorbidities that you have to plug into a risk calculator, and based on administrative data sets show increase in risk. People do not use these risk scores because they are cumbersome to use and not convenient within the circle of care. We looked at two simple variables, length of stay and number of emergency visits in the preceding 6 months. And we found that these two variables, computed in the way that is outlined here, that we derived in this data set, predicts readmission or death at 30 days and at 6 months with as much effectiveness or discrimination as the more complex endpoints. And this work is being published in the ESC Heart Failure Journal. We found that relative to those two simple variables, NT-proBNP can improve the discrimination for risk at 30 days, but not by much. So basically, as you see, the L is the length of stay in days, and we have a score for each group of length of stay on the left panel. E is your number of emergent visits in the prior 6 months, and we have a score allocated to each number or grouping of ED visits. And then we have a score allocated to each class of NT-proBNP admission or discharge values. We found that the discharge values were slightly better in predicting risk, but not much better than admission values, which we found are used more commonly because they're easier to use. Apparently, people discharge patients with heart failure at the drop of a hat without enough notice, so the discharge values don't get measured. But NT-proBNP added to the discrimination, not by much if you don't use it. So length of stay and emergent visits can predict outcomes in a robust way. This is another project of ours that has been accepted for publication. We looked at 1,700 patients with heart failure who were hospitalized for heart failure, and we used unsupervised machine learning, so cluster analysis, artificial intelligence, separating the patients based on comorbidities alone. And this algorithm generated 6 phenotypes based on simple comorbidities. We then looked at each of the clusters, which are shown here. The clusters were separated as follows: patients with coronary artery disease, those with severe valve disease, those who had cardiac risk factors, but no other major comorbidities, those who have atrial fibrillation, those who have COPD, and those who have sleep apnea. We then compared the risk prediction using the simple phenotype classification with the traditional EF classification. So patients in this group had heart failure, but they had the range of EFs from preserved EF to reduced EF. And we know that among patients with preserved EF, phenotypes make a difference in terms of predicting risk. But we, for the first time, showed that this is applicable across the range of EF. Look at these curves, which show the survival-free all-cause death or readmission. The panel on the left is your phenogroup classification system, and you can see it separates outcomes really nicely. The panel on the right shows the EF classification. So the nomenclature of preserved EF, reduced EF, mid-range EF does not separate outcomes and predict risk to the degree that our simple phenotype classification system does. Finally, I'm going to transition to the final transition care period, which is end-of-life care. So advanced heart failure or end-of-life or end-stage heart failure is characterized by progressive failure of tolerating therapies, progressive symptoms despite underlying causes being addressed and drug therapies being optimized, and recurrent hospitalizations, anaerobic metabolism. This stage, the focus must transition to either referring the patient for mechanical circulatory support or transplant if they're candidates, or starting to discuss end-of-life care. This is a recent publication, so most of these papers are in the last year, but showing the temporal trends and sex differences in end-of-life care in adults with heart failure. We looked at 400,000 deaths among patients with heart failure in our province, and about 51% were women. We found that hospital care, invasive care such as cardiac catheterization, coronary revascularization, hemodialysis, intubation, were less common in women than in men. Inpatient deaths were less common in women than in men. Factors associated with in-hospital death were complex comorbidities, recent presentation to the emergency department, which makes sense, and hospital bed capacity. So we tend to admit more patients at the end of life if we have more beds to fill. Factors associated with dying at home included older age, female sex, higher socioeconomic status, and importantly, provision of ambulatory palliative care services to patients with heart failure, which is a rare feat in many healthcare systems. The X labels here, I don't know what happened, but the left two clusters show 6-month cost of care at the end of life among patients who die in the hospital. And you can see that these two clusters are quite different. So the left-hand cluster is a 6-month cost of care in patients who die in the hospital, and the next one is a 6-month cost of care in patients who die at home. So you can see each of the bars in a cluster represents progressive years. So cost of care in the last 6 months of life and in the last 1 month of life among patients who die of heart failure has increased over time. But among those who die in the hospital, the entire 6-month cost of care is much higher than those who die at home, primarily because of palliative care supports. The next two bars show the same, but for the last 1 month cost of care. So the third bar, number 3 on the x-axis, shows the last month cost of care for those who die in hospital. And the fourth bar shows the last month cost of care in those who die at home. Again, over time, the cost of care has gone up, but dying at home is much cheaper for the healthcare system than dying in the hospital. Importantly, most patients with heart failure, another research study shows, and I don't have the slides here for it, I thought I'd run out of time, that patients prefer to die at home and do not want to die in the hospital. So by affording them supports to die at home, we respect their wishes and also reduce healthcare costs, a large part of which are probably futile costs. Goals of care, advanced care planning should involve communication about prognosis, confirming the patient's values and preferences, establishing who their surrogate decision maker is, talking about code status and modes of death in patients with heart failure, so dying suddenly versus dying of a progressive shortness of breath, discussing deactivation of defibrillators. You can leave the pacing function intact and deactivate the defibrillator so patients have a compassionate end of life, sudden death. Most do not like the progressive shortness of breath option, and referring the patient for specialist palliative care, including hospice care, which many of our patients do not benefit from. This is a slide that shows a collaborative work with a colleague of mine, Professor McMaster from the UK, which showed that heart failure is only one among many causes of readmission following heart failure hospitalization. So 70% of the causes of readmission are not due to heart failure. They're due to other cardiac conditions or due to non-cardiac conditions, commonly respiratory conditions. So think of your COPD patients, and infections. So think about your COVID vaccinations and your influenza vaccinations, because these infections increasingly will bring your patients in after hospitalization for heart failure. In summary, in your patients with heart failure who are hospitalized for heart failure, seek to address the underlying cause, optimize medical therapies, keeping in mind that the only two classes in this list that have been tested in NYHA class 4 patients are the ARNIs and the MRAs. But we know from ambulatory patients that they benefit from the other classes, including SGLT2 inhibitors, beta blockers, ACE inhibitors. Keep in mind that the SGLT2 inhibitors and the ARNIs have not been tested in the immediate post-MI population. So in your patients who are coming in with MI complicated by heart failure, you want to stick to the ACE inhibitor, beta blocker, MRA combination. Initiate therapies in the inpatient setting. I didn't talk about soloist, but that sotagliflozin has a combined SGLT2, SGLT1 inhibition, and it was tested in diabetics with heart failure across the range of EF, and it demonstrated efficacy in that population. There are trials now looking at SGLT2 inhibition in the inpatient setting, which will give us the answer about initiating SGLT2 inhibition in patients with HFrEF in the inpatient setting. But many of our patients, more than 50% with HFrEF, have diabetes, so consider adding it prior to discharge. Keep in mind that the historical testing of sequential drug classes has no biological rationale, and so it's conceivable that you have a lateral approach to initiating therapy with all of these classes at low doses, and then up titrating them longitudinally. I didn't present the TRED-HF trial, but it was a small trial that showed that it is preferable to continue medical therapies even after your EF recovers. TRED-HF had about 50 patients. It was a crossover design, and it showed that patients who had withdrawal of therapy after their EF recovered were more likely to have a heart failure deterioration than those who had continuation of medical therapies. I shouldn't have removed that slide. Refer your patients for healthcare services, focusing on nurse home care visits, nurse care coordination, and heart function clinics. Assess and address non-cardiac comorbidities, and please address end-of-life care needs, which can involve difficult conversations depending on where the patient and their family is at, but which consumes a lot of resources, emotional resources on the part of the patient and their family, healthcare cost resources on the part of the healthcare system, and is a cause of frequent readmissions unless other models of care are put in place. I'm leading other trials in digital health, both for end-of-life care and also heart function clinic and transitional care. So reaching patients where they are through digital technologies. I didn't present all of that here, wanted to keep it simple. I hope you've enjoyed the talk, and I'm happy to take your questions.
Well, thanks, Harriette. That was great. I'm sure there's some questions here because we got a really active heart failure group in Calgary. So any questions are welcome. So let me ask you, so how do we change these things between men and women care?
Should I stop care? Yes.
You know, you did show in your trial that, and that's the other thing, you know, most interventional trials, like, you know, most KT trials have been negative, regardless of the intervention, you know, And so
Not
what?
negative, Carlos, neutral.
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 Okay, neutral. Let's say neutral.
Any result is positive if it's a well-conducted and designed trial.
There you
But
go,
yes,
neutral.
neutral.
But
Yes.
let's admit that they're neutral, but they haven't been as positive as we want to expect them.
Right.
We
No
always say,
standing ovations at the late breaking sessions where I'm presenting these neutral results, but the drug guys get their claps because they're all positive trials.
yeah, but I
But
mean,
I
how
know
do
what
we
you mean.
change that? What are we doing wrong in these trials? Do we have something wrong with the design, with the intervention? Okay, you did show that women actually benefited quite significantly, men did not. But how do we change that trend?
So trial design is a clever thing. You can design a trial to show efficacy, or you can design a trial to test effect. And the difference is, in mechanistic trials designed to show efficacy, we pick the patients most likely to derive benefit from the intervention. We pick outcomes most sensitive to the intervention, and we pick patients who are least likely to have any adverse outcomes from the intervention. We can also do lots of things in terms of how to analyze, number of events, time to first event, et cetera, et cetera. In a pragmatic trial, which is typically the one I do because I partner with our healthcare decision makers, so provincial and federal authorities, and patients, and we want to know how interventions work in our clinical settings. So we don't have restrictive eligibility criteria, and we tend not to micromanage how care is delivered, how the intervention is delivered, because each healthcare system has their own can of worms, limitations, and we have to work. It's really a harder thing to do because you have to go to each site, look at their care processes, how you can overcome some of the obstacles in advance. And for example, 3 of the hospitals that enrolled in this trial of mine, the one I presented, did not even have heart function clinics. So I helped them develop heart function clinics first. And so, it's different because you're not trying to show efficacy. You want to show whether there's actual effect. So there is an issue of the trial design in itself, which could be changed if you wanted to test efficacy by cherry picking patients, in which case you eliminate, a good 3/4 of your patients who are actually receiving care. And you then do a more individual level versus a cluster level analysis. And you pick outcomes like heart failure readmission and cardiovascular death. But the reason drug trials do that is not because non-heart failure readmissions aren't more a reason for readmission. It's because the outcome is sensitive to heart failure drugs, right? Your flu rates aren't going to go down if you're giving a heart failure drug. Your heart failure readmission rates might go down. So there's many aspects of why these pragmatic trials end up neutral, and we want to know what the effect is. Now, it's also important that we consider the mechanistic results, which is what my meta-analysis showed, that those interventions are effective in cherry-picked patients. So it's a matter of picking the right patient and tailoring the intervention to the patient. But our trial answered an important question because the ministry wanted to implement some of these services at the global level. The second thing is to think about the importance of the outcome. What is important to a patient with heart failure? At some point, death is not an important outcome to them. They are fine with dying. They want a good quality of life. So in retrospect, the outcomes that we chose as secondary outcomes, which are the patient-reported outcomes, health-related quality of life, satisfaction with care, preparedness for discharge, self-efficacy, those could have been the primary outcomes, because for the patients we were intervening on, many of whom are in their late 70s, many of whom are dependent on care, those were the outcomes that would have been most relevant. So choosing clinical outcomes for a health service research trial is probably not the right thing to do, and I've learned from that and certainly taken lessons moving forward. But I will always design my trials with a more pragmatic flair. I don't owe anything to any company, they're not right, their profit margins aren't riding on the way I design it. But B, I want to know in our healthcare system, what are the effective things that are worth investing in to improve the patient's experience of care, quality of life, and survival if possible. That's my long-winded answer to your question.
So the other thing you showed that was interesting was that Lent risk score, and couple of thoughts on that. So on the one end, how do you implement this to really try to have some reduction in health resource utilization? And on the other end, is there a group that you identify with this that you would just steer directly to palliative care?
Oh, that's an important question. Heart failure death is easier to predict than heart failure readmission. And most of us probably don't need a risk score, but a risk score could help. I haven't actually looked at that question of whether the score could be used selectively to establish who needs palliative care or not. That's a very interesting idea, Carlos. We've looked at these scores in order to establish who's at high risk of readmission so that we can tailor the post-discharge follow-up, so to help avert readmission. But I should also say that no risk score that includes heart failure readmission or any readmission, we looked at all-cause readmission, predicts risk with as good or discrimination as risk scores that predict death alone, because there's so many different non-cardiac causes and socioeconomic causes and health support causes of readmission. But important. And then you had asked me a question about how to close gaps in sex differences in care, because we know in heart failure, reduced ejection fraction, mid-range, any ejection fraction, women are less likely to receive guideline-directed medical therapy. They're less likely to be referred for health services such as disease management clinics, less likely to receive cardiac resynchronization therapy and ICDs, less likely to receive anticoagulation, and so more likely to suffer from strokes. And we could improve outcomes in women much more than we can in men at this point, because there's so much of a gap to fill. The ways to do that are to be wary of implicit biases as a clinician. For whatever reason, all of us, even though we're woke, tend to under-refer, under-diagnose in women. So we need to be aware of these implicit biases that somehow, even last night on service, last week on service, there was a woman with heart failure who'd been in and out of Emerge and been diagnosed as having anxiety, and she had heart failure when we saw her. So maybe the way we diagnose and risk stratify patients can be devoid of implicit bias when we use risk scores. But we need to be mindful of them. The second thing would be to shore up our focus on improving heart failure care to women specifically, and this could be done through clinics that focus on women and heart disease, and also through capacity building among women cardiologists. So recruiting, retaining, promoting women cardiologists. We know from the emergency doctor setting that women care providers, women clinicians, provide care in such a way that women patients presenting with MIs have better outcomes when they're seen by an emergency department physician who's a woman. We don't have this data among cardiologists, but I would say based on what we've seen in terms of women clinical trial leaders associated, and the association with enrollment of women in clinical trials, the designing of a trial around the needs of women may be a factor why we see that association. We need to build capacity among our colleagues who are women, among our trainees who are women, and transform the culture so that more women want to provide care, that this does close the gaps. And then I would say that among patients and clinicians who have conversations about interventions, we need to be mindful of the fact that women are risk averse and tend to decline invasive care options that they perceive as risky. So consent may be an issue that we have not yet addressed in terms of why there are differential rates of invasive care in women and men. It may be a small component of the differences that we see. So how we communicate risk and the importance of communicating the benefit of the intervention may be even greater in women. We all tend to communicate risk in the sense of interprocedural risk, right? You talk about cabbage and you say the risk of death is 1%, but we don't talk about what the risk of death is without cabbage in this patient presenting with high risk ACS who has LV dysfunction and multivessel disease. So the risk discussion has to be balanced, where women and men can see the benefit of the intervention and make a decision and a choice based on that important context, without which they would probably tend to decline. This risk issue does not reflect under referral for many other types of services, but definitely we see that, at least in clinical trials, the invasive interventions tend to have less women enrolled in the trial. And one of the other research studies I'm leading right now, Carlos, has to do with sex differences in consent and trial flow, which is never reported in any clinical trials, but we're hoping to tackle through our current work.
Great. So there's some comments and questions there in the chat, and one is from Jonathan Howlett, that is one of our heart failure guys. And
yes, hey Jonathan.
So he thanks you for your comprehensive talk, Harriette. In Alberta and elsewhere, we see a slow change and reduction in hospital readmission over time, which we have found must be accounted for in assessment of QA interventions. Did you see a change in readmission rates during PACT over time? And if so, did this impact your power calculations?
So Jonathan, this is very much related to what we were chatting about at our last meeting, that a lot of QA metrics do not account for background changes in prevalence, right? Background changes and trends of readmission rates. And you have a before-after methodology where it seems that the intervention is effective. And in PACT-HF, we saw across hospitals using a before-after methodology, I should probably publish the work, that the readmission rates decreased. They decreased in all of the hospitals, but not when you adjust for the background change in hospitalizations across the province, and not in the cluster randomized analysis, the crossover analysis that we did that accounts for within group changes as well as between group changes. So they were within group changes over time across our sites, but also across all of the sites in the province, really. So it brings to mind the importance of clinical trial, even clinical trials, even in health service interventions that typically do not have the benefit of somebody sitting and designing a trial and testing things in a proper way. Most sites only measure their own rates before and after the intervention, and it is not a reliable way. So when we present our quick wins at meetings, this is how we implemented a service and this is the effect we saw. It's really not effect, right? It's sort of a trend we saw in our site, and it needs to be put in the context of we have not robustly designed this to reflect effect, right? We're measuring before and after, and it may be that all of these other caveats are occurring, but we need to bear that in mind. So yes, if this was a before-after trial, I would say that the intervention was effective at improving clinical endpoints. Given the benefit of the trial design and our proper analysis, I could say that there was no benefit overall, and that the benefit overall was in patient-reported outcomes, which is still important.
Great. So another question from Sophia Ahmed here that does a lot of our research in women's and
Sophia.
gender. And she wants to thank you for the presentation. She's a huge fan of your work. You think that sex gender-based differences in the PACT heart failure trial are primarily due to potential sex-based differences in type and causes of heart failure, or more gender-based reasons like social isolation, caregiving roles, etc.?
So we know that among patients with heart failure, women are less likely to have ischemic heart disease. They tend to be older, and they tend to have non-cardiac comorbidities more commonly than men. There are sex-based differences, but by virtue of the trial design and the analysis we did, there was balance between intervention and usual care within each sex, and we also adjusted for any between sex differences when we computed the treatment effect. So it's probably less likely due to biological or sex differences that we saw this difference in outcome or response to our intervention, and more likely due to differences in baseline support services that women are offered versus men are offered, because we didn't measure that. But we know from other studies that women, for example, are less likely to be referred for some of the services that we referred them for in the context of the trial. It's also possible that the lack of support that women have, so we know that in many settings, women tend to be the care providers, but women with heart failure are on average 5 years older than men with heart failure. So men with heart failure more commonly have spouses who live with them, who are the next of kin, who come to their appointments and provide care at home, whereas women with heart failure more commonly tend to be widowed. Now, we didn't collect this data as part of the trial, so I don't know that this is true, but it's possibly true that they just didn't have as much support in their home. And so having the nurse home visit and having the frequent heart function clinic care differentially afforded them greater benefits than those same interventions did to men who may have adequate support at home. So I have a feeling that this is more gender-based rather than biological-based, but I can't be sure because we didn't test that.
Well, that's great. So let me ask you the last question. So you talk a lot about, women, we need more women in the emergency room, women in the cath lab, women everywhere, which is fine. But
we need women everywhere.
I agree, but can we men learn how to approach these diseases in women? Is there like a playbook for us?
I think Sophie and I are going to write a playbook just for you, Carlos. I'm just kidding. Yeah, well, it's sort of, hard to say. It may, it may be the communication in combination with just a view for advocacy. I would say that the best thing all of us can do, because I hate to make blanket statements myself. I've had great women and men mentors and sponsors. I personally haven't seen a difference in a blanket kind of way, but in terms of the research evidence, it does point us in a different direction than I could anecdotally comment on. I would say that sticking to algorithms of care, sticking to risk scores, somebody comes in with an MI, use a GRACE risk score, use a risk score that helps you objectively assess what the patient's prognosis would be, and have your treatment algorithms follow that risk assessment, which has been validated and which could help you overcome any biases you have. I mean, I have implicit biases.
But they haven't been that well validated in men and women. That's part of the problem.
Say that again? Many of
these risk scores have not been really validated in men and women. So I guess that's part of the problem.
That is part of the problem, but even that would be a step up because there's also risk scores based on observational data where women are very well represented. So actually a majority of risk scores are derived from administrative data sets. But you're right, the issue is larger, and I could have done one talk alone on what we need to do, and I'm leading a global task force and actually closing gaps and research leadership, where we bring up all of this evidence at every level where there are differences in outputs, grants, journals, trials, research design, there's so many differences and so many different levels that we need to tackle in order for these gaps to close. But I would say that any risk score is better than no risk score, just to help you overcome cognitive biases. And the biases may not necessarily be gender related. For some, it may be, you might have a bias that you're not aware of against smokers or with obese people, or some, demographic criteria. We know that Black patients, Indigenous patients receive poorer care. And it's not about, it's about recognizing some of your implicit biases, and implicit bias testing can help. But B, it's about using whatever we do have at our fingertips to be more objective in decision making. And then C, it's to meet patients where they are. I think sometimes all of us women and men tend to be top down in the way we communicate and the way we ascribe and prescribe treatment. And I think engaging the patient more works for broader groups of patients. It works in trust building. It works in adoption of therapies and recommendations. And it probably translates to better outcomes, but approaches that I use in patient A may be extremely ineffective in patient B. And I think the gender differences, cultural nuances, the history of race relations, all these things need to be kept in mind when we communicate. But there's so much research evidence to unearth to actually know what the right approach is. I can't say we know what the right approach is, but I think in general, diversity, not just men and women, but diversity in engaging people from different communities, we know creates for better research design, better clinical outcomes, and better clinical care, a better satisfaction with care. So I think diversity in all of its forms, gender, race, age, geography, mindset, idea generation, is important. It's important in academic life, it's important in clinical life, and we need to nurture and encourage it rather than in some places we see it squashed, and it's a shame.
Well, Harriette, it was great. Thanks again for spending this time with us, and hope to see you soon, and let's go Red.
Thank you for having me. Let's go Red, guys. Bye now. Thanks,
Bye.
Calgary.